So, very good evening, all. So, like yesterday, today we are going to start with a very interesting and very important topic from your clinical practice. That is going to be your CA pancreas. Hope you are all audible and hope my screen is visible. So, I want you all to be with little interactive so that the session goes interesting. So, let me start like yesterday. So, we are going to today deal with CA pancreas, but just forget that we are going to study about CA pancreas. Just tell me now a patient is going to come to you with jaundice, and the patient is going to give you history of pruritus, and the patient is going to give you history of gray colored stool. Gray colored stool. What will be your diagnosis? What will be your mindset on seeing this patient? You're going to have a patient with jaundice, pruritus, gray colored stool. So these are the three things with which the patient is going to come to you. So what will be your next question? You're going to ask about whether there is a fever history. Then you're going to talk about whether there is a history of abdominal pain. Then you're going to ask any history of any jaundice. So already jaundice is there. You're going to ask how many days you're going to get jaundice. And main important thing apart from these things is you're going to ask the time duration. You're going to ask whether the patient is going to have a intermittent fever, intermittent pain, and intermittent jaundice. So the intermittent pain, intermittent fever, in an intermittent jaundice, these three are together called as Charcot's triad. Charcot's triad. So what is this Charcot's triad? Charcot's triad is going to be an important diagnostic triad for obstructive jaundice. Along with this Charcot's triad, you're also going to ask two more history. What is the two more history? You're going to check for this. I can tell it as a sign. You're going to check whether there is any signs of septic shock. And second thing, what you're going to see, you're going to see if there is any altered mental status seen. Okay, altered mental status seen. So together, along with the Charcot's triad, along with that, if you're going to have these two conditions, this is called as pentad. What pentad? You're going to call it as a Reynolds pentad. Reynolds pentad. Okay. So now you're going to do a clinical examination. You're going to find all these histories and all these signs. Now you're going to check for whether there is any signs of jaundice. You're going to see whether there is any signs of jaundice. Okay, if you are going to see signs of jaundice, what do you do next? You're going to see whether there is any lump. While doing examination, you're going to see whether there is any lump. So if lump is negative, you're going to have either lump will be negative or you're going to have a lump positive. Okay, so if the lump is negative or the lump is positive, next you have to go for another important thing, that is going to be the next step of investigation. Before moving to any investigation, what should you do? You have to do a proper clinical examination. Now, how this lump is looking like? So I am an examiner. I am just seeing the patient. I am just examining the patient and telling that there is a lump. And this is going to be globular in shape. This is going to be globular in shape. And this is going to be present in the right hypochondrial region. Hypochondrial region, right hypochondrial region. And it is going well with respiration. Move well with respiration. So this is the typical finding I'm going to tell you. And I'm also having jaundice. Remember, I'm also going to have jaundice in this patient. So what is going to be my suspect? Anyone? Can you tell me what might be the suspect in this patient? What might be your thinking in this patient? Come on, just put it in the chat box. What is going to be your suspect in this patient? So you have to think about periampullary carcinoma of pancreas. Whenever you're going to have a patient with Charcot's triad and you're going to have a clay-colored stool and pruritus, and when you're going to do examination, you find a globular mass in the right hypochondrial region, which is moving well with respiration, and the patient is going to show you the signs of jaundice, then you have to suspect what? Obstructive jaundice is there. Then you have to suspect for a CA pancreas, that too in the periampullary region. So you wanted to confirm your diagnosis, isn't it? So what you're going to do, even if the lump is negative or if the lump is positive, next step is going to be LFT and USG. So you're going to take a liver function test and you're going to go for a USG, okay, ultrasound. So now the result can be as follows. Either it is going to be the direct bilirubin can be raised, and you can have a ALP, GGT can be raised. Okay, or your USG can show a gallstone. USG can show a gallstone presence, and there can be a CBT dilatation. CBT dilatation. Okay, or the third chance is, yes, of course, the liver function test is elevated, but your gallstones are negative. There is no gallstones at all. But what you can find is there is going to be a distended gallbladder. Distended gallbladder. Distended gallbladder can be seen, and it is not going to have gallstone, and you are also going to have CBT dilatation. So in one case, you are going to have raise in direct bilirubin level, ALP, GGT level is going to be raised. In second case, so USG, you're going to find a gallstone, and CBT dilatation is present. In the third case, you have a raised LFT. You're going to have a no gallstone, but it is like CBT dilatation is also there, distended gallbladder is also there. Now, what should be a suspect? Remember, when in these two cases, in the case A and case B, there can be no malignancy. You have to suspect for CBD stones. CBD stones tomorrow, let's see it. But today, what you have to understand is, so you have to suspect for malignancy if you are going to have a tumor, if you are going to have a globular mass, which is moving well with respiration, and on LFT, you raised LFT enzyme values are raised, and you're going to have no gallstone, but there is a dilatation of your CBD, and you're going to have distension of gallbladder. This typical history denotes that there is a chance of malignancy. So what you're going to do here? So you're going to suspect a malignancy, and what you're going to do? You're going to evaluate for the malignancy. So now you're going to start evaluating the patient for malignancy. Clear, right? So now you're going to start evaluation for malignancy. What do you do for evaluating your malignancy? What will be your next step? Can you tell me what is going to be the immediate step after you found that there is going to be an abnormality in the USG and there is a raised LFT? What will be your next step? What is going to be your next step of management? Can you put in the chat box? What will be your next step of management? Can you put in the chat box? Come on. What will be your next step of management? You are going to go for CT scan. Very good. So you're going to perform a CT scan. So why do you perform a CT scan? So you're going to check whether you're going to see where exactly you're going to have the pathology. Remember, CT scan cannot detect. It cannot detect when the lesion is going to be less than 1 centimeter size. Okay. It cannot detect when the lesion is going to be less than 1 centimeter size. That is a problem. If you cannot detect it, then you're going to go for a endoscopic ultrasound. You're going to go for endoscopic ultrasound is the next step of management. If you cannot detect the size, when it is less than 1 centimeter, you're going to go for a endoscopic ultrasound. After doing endoscopic ultrasound, you're going to see whether there is any pathology or not. Okay. In the CT scan, if you're going to see, there is going to be involvement of head. So there is going to be a lesion in the head of pancreas. Next, what you're going to do? You're going to confirm it by the PET scan. You're going to confirm it by the PET scan. So now you have got to a diagnosis that my patient is going to have a head of pancreas cancer. So I'm going to have the CA head of pancreas. How I am going to proceed? Remember, if I am going to finalize that my patient is going to have a CA head of pancreas, okay, then I am going to perform CT scan. I am going to perform a PET scan. I'm going to perform a PET scan. I'm going to perform a CT scan. In the PET scan and CT scan, why do I perform? Why do I perform PET scan or CT scan? There must be some reason, right? Remember, write it down. Why do you do CT scan and PET scan? To identify distant metastasis. I'm going to identify the distant metastasis. So where all metastasis can occur? Metastasis can occur either in the liver nodule, okay, or it can go to the ascites. It can go to the peritoneum and cause ascites. So that is called as malignant ascites. Third thing is going to be your Troussier's sign. So Troussier's sign can be there. Number 4 is going to be your Blummer shelf. Number 4 is going to be a Blummer shelf. And number 5 is going to be your Sister Mary Joseph nodule. Sister Mary Joseph nodule. And I hope that you all know what is the meaning of this as a Trousius sign, Blummer shelf, sister Mary Joseph nodule. If not, kindly put in the chat box. I'll tell you. But now I'm not going to explain you without your requirement because we have very limited number of time. I want to make this a very short video so that you can just quickly revise whenever you are finding time. Okay, so this is going to be the first important finding which we are actually looking for in the CT and PET scan. Number 2 is going to be, we are going to see for the celiac and portal lymph node enlargement. Portal lymph node enlargement. Okay, now that is number 2. And number 3 is going to be, we are going to look for superior mesenteric artery invasion. Superior mesenteric artery invasion. And we are going to look for the extensive involvement of superior mesenteric vein and your portal vein. Okay, so in all these things, you are going to perform a CT scan or your PET scan. Now, I am going to have a CA head of pancreas, I am suspecting, but there is no ultimate symptom, or if pathology is not suspected. I am performing endoscopic ultrasound. In the endoscopic ultrasound, I am not going to see. Remember, in endoscopic ultrasound, there is no stone. So I am not seeing a stone. Then I am going to perform this. This is going to be your laparoscopic staging. Then I am going to perform laparoscopic staging because here I am not able to find the size of my CA pancreas because the size less than 1 centimeter will not be visible in the CT scan or PET scan. So I am not going to perform that. Instead, I am going to perform a laparoscopic staging. So laparoscopic staging, when I'm going to perform, I'm going to take it into 2 steps. Okay, so I'm going to see whether I'm going to have any advanced cancer or there is no advanced cancer, If there is no advanced cancer, if my patient is not going to have advanced cancer, then what I'm going to do? Then I'm going to perform Whipple's procedure. So what is Whipple's procedure? Whipple's procedure is nothing but it is pancreatico-duodenostomy. So you're going to perform pancreatico-duodenostomy. Okay, so then you're going to perform a pancreatico-jejunostomy. So it's going to be a mixture of pancreatico-duodenostomy and pancreatico-jejunostomy. Then this is going to be a Whipple's procedure. Second thing what I can do is I can go for a pylorus preserving Whipple. So I can go for a pylorus preserving Whipple. So what is this pylorus preserving Whipple called as? It is actually found by long wire and transverso. Therefore, it is called as long wire and transverso procedure. Okay, so first is going to be a Whipple's procedure. Second, if I want to if I want to preserve my pylorus, then I am going to do a long wire transverso procedure. So what is this Whipple's procedure? First, you're going to remove the gallbladder. Then you're going to cut your CBD. You're going to cut the common bile duct. Then I'm going to cut the stomach. Then I'm going to perform pancreatico-jejunostomy. Then I'm going to perform what? Then I'm going to perform hepatico-jejunostomy. Then I'm going to perform gastrojejunal anastomosis. So this is called as your Whipple's procedure. So what I'm going to do exactly is the plane between your pancreas and the superior mesenteric vessel. That area, I'm going to insert my finger and I'm going to do a pancreatico-jejunostomy. And this area where I'm going to insert the finger, that is called as tunnel of love. Clear, right? So all clear. So this is going to be your staging laparostomy, what you're going to perform. But the problem with all these procedures, Whipple's procedure, is the most common cause of death. In this procedure is going to be anastomotic leakage. Okay, so there is a more chances of anastomotic leakage. Clear, right? So this is all about your Whipple's procedure. So complication of Whipple's procedure is there are 4 complications. One is going to be impaired gastric emptying, hemorrhage, but most common cause of death is going to be anastomotic leakage, and CVS, cardiovascular system problem, can occur and recurrence can be there. And these are the problems with your Whipple's procedure. Okay, now if there is an advanced cancer, I am going to see what is my problem. If my patient is going to have jaundice, or if my patient is going to have my patient is going to have gastric outlet obstruction. If it is a jaundice, I'm going to perform hepatico-jejunostomy. If my patient is going to have gastric outlet obstruction, then I'm going to perform gastrojejunostomy. Now, next problem is What are the structures removed in the Whipple's procedure? So write it down. In Whipple's procedure, what are the structures that are going to be removed? Number one is going to be your duodenum. Number two is going to be your head of pancreas. Head of pancreas. Number three is going to be your gallbladder. Number four is going to be a bile duct. And number five is going to be a lymph node. So these are the structures that are removed in the Whipple's procedure. Okay. So now when you are going to have a distant metastasis, or whenever I'm going to have a celiac portal lymph node enlargement, or when I'm going to have a superior mesenteric artery invasion, or when there is going to be a extensive involvement of your superior mesenteric vein or your portal vein. Next step, what I'm going to perform. See here, when I'm going to confirm that my patient is going to be having advanced cancer and all these problems, what I'm going to do is I'm going to go for a endoscopic guided biopsy. I'm going to perform endoscopic guided biopsy. And on performing biopsy, I'm going to do, next step is going to be either go for a chemo or you can go for a palliative treatment. Palliative treatment. So what is meant by palliative treatment? To reduce the pain of the patient. So you have to go into reduce the pain of the patient. You have to reduce the jaundice. You're going to reduce the gastric outlet obstruction. For gastric outlet obstruction, either you can go for a endoscopic stenting or I'm going to go for a gastrojejunostomy. Okay. If my patient is going to have jaundice, what can I do? I have three options available to reduce the jaundice. Again, you can go for endoscopic stenting, which is most preferred, or I can go for surgical bypass. How can I go for surgical bypass? By doing hepaticojejunostomy, which is the best method. And for doing your, and also PTBD, if the patient is going to be very sick. If my patient is going to be very sick, I am going to perform this. Okay. And for reducing the pain, you go for radiotherapy. And now coming towards your chemotherapy, what is going to be your regimen followed? Fall, Fury, Vox. What is this fall, Fury, Vox? You're going to give 5-fluorouracil, leucovorin. You're going to give leucovorin. Then I'm going to give folinic acid. Then irinotecan, and finally oxaliplatin. This is the regimen that is followed in your CA pancreas. Okay, this is a regimen that is followed in your CA pancreas. That's all. For staging, you're going to use PET-CT. Investigation of choice is CECT. MRCP, you're going to find. So I can also perform MRCP. MRCP, what is my sign I'm going to get? That is going to be my double duct sign. And duodenography can be performed where I am going to see a reverse 3 sign. In duodenography, I'm going to see reverse 3 sign. Okay, wow. So all these things are going to be additional points for you. Now, what are the causes of CA pancreas? Now I have discussed the treatment. I have discussed what are going to be the symptoms the patient comes to you, and all those things I have discussed. Now coming to the causes of pancreatic tumors. So pancreatic tumors, first cause is going to be diabetic mellitus, alcohol, then you're going to obesity. Obesity is another important cause. And then you're going to have genetic cause. What is the gene that is commonly involved? Genetic cause is going to be PRSS1 gene. Write it down. PRSS1 gene is the most common cause. And fifth is going to be your SPINK1 gene. So you're going to have another one gene that is going to be your SPINK1 gene that is going to cause calcific pancreatitis. And the chronic pancreatitis is also going to be one of the cause. And there are various syndromes. And most common syndrome is Peutz-Jeghers syndrome. Peutz-Jeghers syndrome is 100 times more risk of developing a CA pancreas. And a very important genetic mutation that is going to occur is, first there is going to be a mutation in KRAS, then there is going to be a mutation in P53. Okay, so there is going to be a molecular genetic progression from pancreatic intraepithelial neoplasia to invasive ductal adenocarcinoma. And most common place where you can have is going to be your periampullary region. Periampullary region, that is going to be 2 centimeter of your ampullary opening. Ampullary opening. 2 centimeter behind your ampullary opening is the place where you can get most commonly this CA pancreas. Okay, guys. So resectable tumor on the, you're going to perform Whipple surgery. If it is unresectable, you're going to carry down with the palliative management. And what is going to be the marker? So what is going to be the marker? So this can be asked. Marker is going to be CA19-9. CA19-9 is the most important marker. And what is going to be the prognostic factor? Prognostic factor is going to be the stage of disease. Stage of disease is going to be the most important prognostic factor. This comes to the end of the important CA pancreas. Now you might ask me, sir, CA pancreas, will it occur only in the exocrine gland or it can also occur in the endocrine gland? Yes, it can also occur in the endocrine gland. It is not that it is going to occur only in the exocrine gland. It can also occur in the endocrine gland. And when the endocrine glands are involved, endocrine glands, when it is going to be involved, you're going to call it as various names. The first one is going to be insulinoma. Insulinoma. What is this insulinoma? It is the most common pancreatic endocrine tumor. It is the most common pancreatic endocrine tumor. Okay, endocrine tumor in pancreas. That is the first important thing. And it is going to involve what cells? It is going to involve your beta cells. Okay, so 90% it will be benign. So in the previous discussion, we saw Whipple's procedure. Here we are going to see Whipple's triad. You're going to have Whipple's triad. So this can be asked as a one mark question. What is a Whipple's triad? First one, when there is going to be a fasting hypoglycemia. Okay, fasting hypoglycemia. Number two, when the blood sugar level is going to be less than 40 mg per deciliter, and there is going to be a rapid resolution on giving glucose. Rapid resolution on giving glucose. So this is called as glucose. This is called as your insulinoma. Okay, ma? So you have to understand how to differentiate between insulinoma and exogenous insulin. So now the patient is very brilliant. He wanted to fool the doctor. So what he is doing, he is going to take insulin shots and tell that, sir, I'm having a low sugar level and I think I have an insulinoma. In that case, what you can find, you have to check for C-peptide levels. So C-peptide levels will be highly raised if the insulin is endogenously secreted. If you're going to administer exogenous insulin doses, it is not going to elevate your C-peptide level. Okay, then what is going to be a gold standard method? Gold standard method is going to be 72-hour fasting test. 72-hour fasting test. And what is going to, how do you localize? You're going to localize by doing a endoscopic ultrasound. Endoscopic ultrasound is going to be the investigation of choice to localize. And what is going to be your management? My management is going to be very simple. If it is going to be less than 2 centimeter, I'm going to perform enucleation. If it is going to be more than 2 centimeter, I'm going to perform a full thickness wall removal. And if it is going to be malignant, it can go to the liver. This comes to the end of the first one, insulinoma, short note. And then second is going to be gastrinoma. So it is otherwise called as Zollinger-Ellison syndrome. So it is nothing but because of increase in the G cells. It is most common in MEN1 syndrome. It is most common in case of a MEN1 syndrome, multiple endocrine neoplasia. So do you all remember MEN? So that is going to be a MEN1 syndrome. Okay, and 70 to 80% they are going to be malignant. What is the other important endocrine gland which is involved here? It is going to be your thyroid gland. It is going to be your thyroid gland which is going to be involved. What is the cancer you get in the what is the cancer you're going to get in your multiple endocrine neoplasia type 1? That is going to be your, yes, thyroid. What type of cancer you can get? What type of cancers you can get? Wermer syndrome. Excellent. Wermer syndrome is the answer. And can you tell me what type of tumor you get in MEN1 syndrome? What type of tumor? Medullary carcinoma of thyroid is most common. So most common is medullary carcinoma of thyroid. Okay. So now you're going to get a patient like this. And what is going to be your clinical features? The patient will have a recurrent ulcer. And these ulcers are actually located in the atypical areas, like your duodenum, fourth part of duodenum, third part of duodenum, first part of jejunum. These places very unusual to get ulcer, and you're going to get ulcer in these areas. And the patient will also have a history of diarrhea. The patient will also have a history of malabsorption. absorption. Now, what you're going to do? You're going to take a investigation. What investigation you do? Serum gastrin level. Serum gastrin level, when it is going to be more than 1000 picogram per ml, it is going to be a diagnostic feature. If it is going to be less than 1000 picogram per ml, what will be your next step? You go for a stimulation test. You go for a stimulation test. So you're going to give pentagastrin. So pentagastrin stimulation test. If the value is going to be raised by more than 200, then the test is going to become positive. So this is going to be gastrinoma. So you have to understand what is the gastrinoma triangle. So this is another important anatomical landmark which the examiners can be asking you in Viva. Gastrinoma triangle. Theory Viva வைப்பாங்கல்ல அதுல கேட்கலாம். What is this gastrinoma triangle? So gastrinoma triangle is nothing but it is going to be something like this. Okay, so it is going to be something like this. So what is this end? This is going to be the junction of CD, okay, and your CBD. Okay, cystic duct and common bile duct. And this is going to be the junction of D2, D3. And this is going to be the junction of neck, okay, neck or head of pancreas, head and neck of pancreas, and the body of pancreas, head and neck and body of pancreas. So this is the triangle. And what is going to be the content? So the contents are going to be, you're going to have your D1. So you're going to have wall of D1. That is going to be your duodenum part 1 or the first part of duodenum. Then you're going to have your head of pancreas. Head of pancreas will be inside this triangle. And third is going to be, you're going to have the lymph node. This is going to be gastrinoma triangle. The problem is gastrinoma triangle is visualized only using a endoscopic ultrasound. Endoscopic ultrasound. This gastrinoma triangle is otherwise called as Passerose triangle. It is otherwise called as Passerose triangle. Clear? Now coming towards your management. What is going to be your management if localized disease? So what is going to be your management if it is going to be resectable? If the disease is going to be resectable, if it is going to be less than 5 millimeter, you're going to perform enucleation. If it is going to be more than 5 millimeter, if it is going to be more than 5 millimeter, you go for a removal of full thickness wall. Removal of full thickness wall. Full thickness wall. Okay, this is going to be your resectable part. So if the tumor is going to be unresectable, if it is going to be unresectable, if it is going to be unresectable, you're going to go for chemotherapy. What chemotherapy you go for? Streptozocin. So you're going to go for streptozocin. Okay, streptozocin. Along with streptozocin, what you're going to give? Since it's a Zollinger release, remember streptozocin, and you're going to give 5-fluorouracil. And you're going to give high dose of PPI, and you're going to give octreotide. Okay, so pancreatic JES with a larger tumor are going to give you a poor prognosis. Now coming to another question, that is going to be gulcagonoma. Okay, what is this gulcagonoma? So this occurs in diabetic mellitus patient. The patient will be having dermatitis. The patient is going to have dermatitis. So patient will have a deep vein thrombosis and the patient will go into a depression. So remember 4D. That's all. This is what you're going to remember in gulcagonoma. Next is going to be VIPoma. What is VIPoma? Vasoactive intestinal peptide noma. So this is going to give rise to Werner-Morrison syndrome. Werner-Morrison syndrome. Werner-Morrison syndrome. So what is going to be the features of Werner-Morrison syndrome? You're going to have watery diarrhea. Watery diarrhea is going to be there. Hypokalemia. Hypokalemia is going to be there. And third one is achlorohydria. Achlorohydria will be there. And fourth one is going to be acidosis. Fourth one is going to be acidosis. Okay, so this is what I want you all to remember. So the very important part is going to be the first part which I took. That is going to be your CA head of pancreas. Then why I talked about the remaining things? Because you will be like messaging me, sir, you have left this portion. That's why I'm just covering that also. Okay, these all can be asked as a 2-mark question or 1-mark question. That's all, not very serious. And I'll add some more points. Remember, so on imaging, on CT. Okay, so these are going to be exactly additional point. Just remember, if you are thorough with all the things which I discussed previously. Number one, what is going to be the CT image? What is the CT image feature of serous cystic neoplasms? Serous cystic pancreas neoplasm, pancreatic neoplasm, serous cystic neoplasm. So what is the CT feature? You're going to get a sunburst appearance. Sunburst appearance. And what is going to be the management of serous cystic neoplasm? Management is going to be excision. This is one thing I want you all to remember. Second one, in mucinous tumor. In your mucinous tumor, what is going to be the CT feature? In mucinous tumor, on CT, you're going to find a eggshell calcification. Eggshell calcification. And what is the other indicator of say, mucinous tumor? So other indicator is going to be there is a rise in CEA, and ER/PR is going to be positive like your breast cancer. ER/PR is going to be positive in the breast cancer. This occurs because there is an involvement in the body or tail. So body or tail-like appearance. Tail, okay, body and tail of pancreas is going to be involved. Very good. It is going to be eggshell calcification and sunburst in your serous cystic tumors. Very good, Kartika. So now coming towards, this is going to be the last and final thing, that is going to be intraductal papillary mucinous neoplasm. So the last thing which we are going to discuss today is intraductal papillary mucinous neoplasm. Mucinous neoplasm. Okay, neoplasm. This is going to be the last neoplasm which we are going to discuss. So what is going to be the appearance in endoscopic? Endoscopy appearance is very important. Endoscopy appearance we are going to see is fish mouth appearance, fish mouth deformity. Okay, fish mouth deformity. And what is this? So this is going to be more common in the male, and on seeing in the ERCP. In ERCP, you're going to do a Ohashi triad. You're going to see Ohashi triad. So what is this Ohashi triad on ERCP? Number one, you're going to have a dilated hepatopancreatic duct. Hepatopancreatic duct. You're going to see Ohashi triad is an important 2-mark question when I was actually studying my final year exam. So dilated hepatopancreatic duct. Number two, you're going to have a fish mouth appearance, fish mouth deformity. And number three is going to be mucin extruding from opening. Mucin extruding from opening. So this is all about your CA pancreas. So once again, I'm going to quickly revise for you all. So are you all ready to revise along with me? Okay, so just 5 minutes, we are going to revise and we are going to close today's session. CA pancreas. So when my patient is going to be having a jaundice, when my patient is going to have pruritus and gray colored stool. Okay, and I'm going to do a clinical examination. I'm going to ask the patient whether they are going to have fever, pain, and jaundice. What is the important key feature in all these three important symptoms? Whether the symptoms are going to be intermittent. So if it is an intermittent fever, intermittent jaundice, intermittent pain, then I'm going to call it as Charcot's triad. Along with Charcot's triad, septic shock, and you're going to also see for altered mental status. When you're going to have all 5, you're going to call it as Reynolds Penton. You're going to do a clinical examination. And what is going to be my next step? I'm going to see whether my patient is going to have signs of obstructive jaundice. What are the 2 important signs of obstructive jaundice? Pruritus, gray colored stool. If both are going to be present, next I'm going to look for whether my patient is going to have a lump. So if the lump is negative or lump is positive, if the lump is positive, how I'm going to describe my lump? It is going to be a globular mass present in the right hypochondrium, which is going to move well with respiration. Now, what is going to be my LFT and USG finding? In my LFT USG finding, if my patient is going to have an increased LFT, or if my patient is going to have in the ultrasound gallstone positive with CBD dilatation, then these 2 are going to favor for a CBD stone. This I'm not least bothered now, because my topic of discussion today is going to be your CA pancreas. Now, if my patient is going to have a no gallstone, but CBD is dilated, if I'm going to have distended gallbladder and with LFT increased, then my suspect has to be a malignancy. To confirm my malignancy, I'm going to perform CT scan. Then, where I cannot get a positive finding in CT scan, when it is going to be less than 1 centimeter size. If it is going to be a less than 1 centimeter size, I'm going to perform a endoscopic ultrasound. In endoscopic ultrasound also, I'm not finding any gallstone. Then I'm going to go for what? I'm going to go for laparoscopic staging. Similarly, I'm going to do a CA head of pancreas. I'm going to suspect. I'm going to check for the CT and PT PET scan. In the CT and PET scan, if I'm going to have a distal metastasis, what are the features of distal metastasis? Liver is going to be having a nodule. Ascites is going to be there. Frossusine, Blummer shelf, there is going to be a Sister Mary Joseph nodule. Then celiac or portal lymph node is going to be enlarged. When the superior mesenteric artery is invaded or there is extensive involvement of superior mesenteric vein or portal vein. Okay, in all these conditions, I'm going to go for the next step, that is endoscopic guided biopsy. I'm going, when after doing endoscopic guided biopsy, I'm very sure that this is an advanced cancer. It cannot be treated as such. So I can go for two options. One is going to be palliative treatment. Second is going to be gastric, second is going to be a chemotherapy. What is the chemotherapy regimen you're going to use here? Folfirivox. What is Folfirivox? 5-fluorouracil, leucovorin, you're going to use folinic acid, irinotecan, and then oxaliplatin. So next you're going to do a palliative treatment. What is going to be my palliative treatment? For pain, I'm going to go for a radiotherapy. For jaundice, you're going to go for endoscopic stenting, which is going to be one method. Then I can go for a surgical bypass, hepatico-jejunostomy. I'm going to just avoid this duodenum itself. Okay, this the part of duodenum from which you're going to have this, that I'm going to completely ignore. I'm going to go for hepatico-jejunostomy, and or I can go for PTBD. Can you tell me what is PTBD, guys? PTBD. Can you tell me what is PTBD? It is percutaneous transhepatic biliary drainage. Okay, so when there is any infection is there, I want to drain, isn't it? So I'm going to go for a percutaneous, percutaneous transhepatic biliary drainage. Okay, it is going to help to diagnose and treat your bile duct obstruction if any present. Next, I'm going to see whether there is any gastric outlet obstruction. If there is, then I can go for endoscopic stenting or gastrojejunostomy. Now, next, I'm going to see whether there is going to be any advanced cancer or if there is no advanced cancer. If no advanced cancer, I'm going to perform a Whipple's procedure. What is a Whipple's procedure? I'm going to remove duodenum. I'm going to remove the head of pancreas, gallbladder, bile duct along with the lymph nodes. Or I can actually preserve the pylorus. What is the pylorus preserving Whipple's procedure called as long-ear transverso procedure? What is the most common cause of death? Most common cause of death is going to be anastomotic leakage. Okay, in advanced cancer, again, jaundice is there, I go for hepatico-jejunostomy. If there is a when there is going to be gastric outlet obstruction, I go for gastrojejunostomy. Okay, what are the causes? Diabetic mellitus, alcohol, obesity, genetic cause, PRSS1 gene, SPINK1 gene, chronic pancreatitis, you're going to have your Peutz-Jeghers syndrome, which is a most common syndrome, and you're going to have KRAS P53 progressive mutation. And most common area is going to be periampullary region, marker is CA19 to 9, and prognostic factor is going to be staging. With this, we are actually completing the today's topic, that is going to be your CA pancreas. Within 37 minutes to 40 minutes, you have completed CA pancreas. It can be asked as a essay question for you all. So we have completed one essay. Yesterday we have completed one essay. Today we have completed one essay. So tomorrow I'm going to give you two choice. Either you can just vote me and tell if you want a CBD injury. So okay. Or if you want a stone, how to diagnose a stone. So you can tell me either if you want to see, if you wanted to learn how to diagnose a stone, or you can tell me how to diagnose or how to treat the common bile duct injury. So because laparoscopic method, common injury is going to be common bile duct. Okay, so that is most commonly seen in clinical practice. So most commonly can be asked as a question for you guys. So two topics I'm going to give you a choice. You can let me know in the group so that I'll just explain you tomorrow. So let's meet you all at 9:30 sharply tomorrow. So tomorrow we will see the next topic. So of your choice, either CBD injury or I will go for the CBD stones. Okay. Thank you guys. See you all tomorrow.